that we will have 2 days. Both days are set up exactly the same with an introduction for a few minutes, which we're doing now, followed by a 2-hour session. Then we'll have a 30-minute break, and then we'll come back for case discussion for a 1 hour and a quick summary at the end of the day. And we try to break it down into some more acute topics versus some more chronic topics, although I think that line is very blurred in the last couple of years. In addition, you see on your bottom right, you see a chat box. There's 2 chat boxes. One is the room chat, and the other is the question and answer chat. Please feel free, if you have technical problems, to use the room chat. But for question and answers, we would like you to try to use question and answer chat so that we can go ahead and get your questions answered. This course will be laid out a little bit different than what I think some of us are used to, besides being a virtual course. And I'm wishing everyone to be safe. I should say good morning, good evening, good afternoon, and maybe some people are even in the middle of the night. And so I'm glad that everyone's here. Please bear with us. This is for some of us, it's as new as it is for some of you. And so we'll do the best to make it as interactive as we can, especially during the case discussions. So, but by using the chat function, especially the question and answer chat, we can get your questions answered. In a small group discussion, we're going to ask everyone to be live and join us, and we'll have some good cases. We also have laid this course out, as I said, a little bit differently than in the past. This is just going to be a case. We're going to get through the topics that we need to cover via cases. There'll be short 5 to 7 minute lectures interspersed with some faculty panel discussions on the cases. So with that, I think we'll get right into it. So here are our learning objectives at the end of the course. We expect you to be able to help describe factors that can help reduce infection risk, the role of the host and bacterial defense mechanisms in biofilms, discuss the importance of early diagnosis and its impact on treatment, use a treatment algorithm to treat acute or chronic orthopedic infections, explain how important stability is to treat infections, and then understand and describe how to use local antibiotic delivery systems in the treatment of osteomyelitis. Why should we all be here? Why? Because we all get infections. Is there any surgeon that says they don't get an infection, we know is not quite being honest. So it's good to understand the basics and be able to treat them. So these are the principles that we're going to try to go over today. You got to always identify the organism. You always need to adequately debride. You almost always need appropriate antibiotics, and you always need stability, whether it's during the infection treatment or if you have infected non-union. So our first case is that of a 67-year-old who was hit while refereeing American football. He had a tibial plateau fracture, and he was 2 weeks post-op when he presented to us wanting to, with a swollen knee and drainage from his knee. And so at this point, I think before we can talk about discussion, we're going to need to discuss the case. We're going to need to know, how do we make the diagnosis? There's been some differences in how to make the diagnosis. And we'll have Wilhelm Metzemaker from Belgium give us a short talk on the consensus recommendations on diagnosis. Wilhelm?
Thanks, Michael. Indeed, next topic will be the diagnosis and more specific, some consensus recommendations. But first, maybe a short introduction. We know that in the field of infection, musculoskeletal trauma research actually lags behind the orthopedic arthroplasty research. Until recently, this was true for translational research, but also more specifically for the clinical research. And therefore, under the umbrella of the AO Foundation, we developed the fracture-related infection consensus group. And the aims were, first of all, of course, to develop some diagnostic criteria, but also diagnostic pathways and treatment concepts for FRI, and we all try to discuss them in the upcoming 2 days. Furthermore, of course, you want to make the scientific data available through publications, websites, and apps, and we'll come to that also a little bit later. And here we see the 2 consensus meetings that were convened, again under the umbrella of the AO, but with other organizations being involved as well. And one of the big topics were the diagnostic criteria to really define fracture-related infection. So let's go through that step by step and see what were some interesting decisions that were made during those 2 meetings. And first of all, it was a unanimous decision that there should be only one single definition for fracture-related infection. So we have no subdivision between acute and chronic. And also very important is that there was a unanimous decision that there should be no subdivision with respect to anatomical location. And more specifically, there is no subdivision anymore between superficial and deep, something to discuss also within the upcoming 2 days. And finally, we know that over the course of the past decades, different terms have been used when we look at trauma and fracture care and infection. Think about post-traumatic osteomyelitis, infection after fracture fixation. But since recently, compared to periprosthetic joint infection, PGI, we want to introduce fracture-related infection, and we'll come to that also later. What about the diagnostic criteria? So we have different diagnostic features, and actually we developed 2 levels of certainty. First of all, there are confirmatory criteria, so this means that the infection is definitively present, compared to suggestive criteria. Over the years, we have now developed 5 confirmatory criteria developed on the most recent literature, and of course, a list of suggestive signs. Let's start with the confirmatory criteria. One of the most important ones is the fistula or the wound breakdown. What do we mean? There is direct contact between the bone and the implant. For example, here we see a visible plate on a clavicle fracture. In this case, in a matter of hours, you will get overgrowth of the commensal flora, in this case, the staph epidermidis, which will form a biofilm on the plate, and this is, per definition, infected. Of course, purulent drainage or visual pus during surgery is a confirmatory sign, and important are the pathogens identified by culture from at least 2 separate deep tissue specimens. This, for example, is a Staph aureus infection on a petri dish. But when we talk about microbiology, we have to talk about sampling. And we know that already previously sampling protocols have been validated for PGI, and they are also now applied for implant-related infection in general, like FRI. Important is that we have to stop all the preoperative antibiotics, and if possible, we would like to avoid them for at least 2 weeks. Also, preferably, we take 5 or more deep tissue samples, ideally from the bone implant interface. We use a no-touch technique. This means that try not manipulate the target area. If possible, use separate instruments. They should be clean and unused. Also, again, to prevent contamination. Don't use superficial skin or sinus tract samples. They have no predictive value. And one key point I want to address as well is that swabs are actually not used anymore. Multiple studies in implant-related infections show that they have a low yield compared to tissue cultures. Histopathology, also an interesting field, was also included as a confirmatory sign. The first sign is the presence of microorganisms confirmed by histopathological examination using specific staining techniques. We focus here on TB, but also fungi. In the definitions of fungal infections, this is a criterion that is also included for other implant-related infections. And more recently, a paper from the Oxford group published that the presence of more than 5 polymorphonuclears per high power field should also be included and is therefore also included as the histopathological sign. But remember, this is only for acute chronic cases. So this means the chronic non-unions, for example, here this sign is also included as a confirmatory criterion. What are the suggestive signs? We all know we have a list of clinical signs like pain, local redness, and swelling. We have important radiological signs. I want to focus here, for example, on non-union. We all know that non-union can be a suggestive sign of infection, but the problem is when we look at imaging modalities in general is that based on the best available evidence of the last 2 decades, data solely focusing on standard X-ray, CT, MRI is actually relatively scarce. When we look at nuclear imaging, more and more data is being published, and we see that white blood cell scintigraphy and FDG PET actually have a high diagnostic accuracy for detecting FRIs. And therefore, focusing on these recent publications, also in the consensus definition, nuclear imaging, including also FDG PET and white blood cell scintigraphy, have been included as a suggestive sign for fracture-related infection. So when we focus on white blood cell scintigraphy, it's important to notice that the accuracy is not influenced by recent surgery, and that it is slightly more accurate than FDG PET. The advantage of the FDG PET is, of course, that we only require a single scan compared to the white blood cell scintigraphy, where we need at least 2 imaging time points. Important to note here is that FDG PET should not be used within the early period of surgery, so within 1 month, and some studies even propose not to use it within a few months of surgery. So in the acute situations, actually overall, these imaging modalities are not standard investigations, and remember, they're also expensive, and they're not all centers available. And this is, for example, an image of an FDG PET, also published in the recent GOT paper from the expert group, where we focus on a fracture-related infection of a femur fracture. Other suggestive criteria are the pathogenic organisms identified by culture from a single deep tissue or implant specimen, but also the elevated serum inflammatory markers. This is absolutely not a confirmatory sign, and studies have shown in chronic cases by the Utrecht group actually that they're unsuitable to rule out or diagnose. Finally, often forgotten is the new onset wound drainage. So we have a dry wound, a good wound within the first 5 to 7 days, and it starts leaking after that period of time. And this can be related to an acute early FRI. And finally, of course, also the new onset joint effusion in fracture patients. We'll see in periarticular fractures around the knee, this can be an important sign of a fracture-related infection. And this is then all combined in these 2 papers. The first is the injury paper in 2018, followed by a recent update of the definition in GOT. And we come then to the diagram, the flow pathway to diagnose fracture-related infection. I want to zoom in just shortly on one of the confirmatory criteria we stressed at the start. So we have our sinus, our fistula wound breakdown. When we have a visual plate, there is a diagnosis of infection. This is per definition infected, even when our culture results are negative. So with this, I'm going to start with some take-home messages. So we know that a well-established diagnosis is the first crucial step. And recently, therefore, also an international accepted consensus-derived definition based on diagnostic criteria was developed. There are 2 levels of certainty with a list of confirmatory criteria and suggestive criteria, but I want to stress that it's important that we try and follow a diagnostic algorithm. And with this, I want to hand over back to Michael.
So back to our case. Here's our x-rays. We can see patient has draining, just some drainage of his wound, and he has a big effusion. You can see here on the CAT scan a little bit of a malreduction as well. You can see a malreduction somewhat here. We can see presence of air in the joint, so we have a joint effusion, and we have some infection next to the plate as well. So again, our treatment options, I'll ask the faculty who will have something to say to come on. 67-year-old, or we'll hold off on that, I'm sorry about that. 67-year-old hit while refereeing, tibial plateau fracture, 2 weeks post-op, presents with a swollen knee and drainage from the wound. So at this point, We also, before we can really talk much about treatment, we have to know about what the body does. And we'll start with some biofilms, and I'll bring up Nick Concaris from University of Leeds to discuss this as well.
Thank you very much, Michael. So we're talking about the biofilm. The biofilm is not a new finding in our understanding on infections. It is many decades now that it has been identified in water filtration systems or as a dental plaque in the oral cavity. And from the 80s, we used the term of biofilm-related infections for soft tissue as well as bone tissue chronic diseases. So for orthopedic and trauma, it should always be suspected, the presence of biofilm. And actually, in more than 80% of the infections we deal with, surgical site infections, we identify or we suspect at least the presence of biofilm. What it is obviously a cluster of cells in a matrix on a surface. And which surface? It could be any surface, natural or synthetic. The matrix is produced by the bacteria themselves in their metabolic cycles, as well as from the host, obviously, response. The bacteria are clusters of bacteria in a special phenotype state. So they have changed from the planktonic active state to a kind of dormant state when they are mature in a biofilm. Which bacteria? Actually, all the usual suspects. All the culture results on biofilms represent basically species that we are well known to us. In 30%, we can find also polymicrobial biofilms, which makes sometimes the situation a bit more complex. The first stage I would highlight is not anything other than the conditioning film forming on top of the implant from blood products, from debris of our procedure, from, other peptides and proteins of the local environment. And then we have circulating bacteria attaching to that initially, planktonic circulating active bacteria. Then they start basically attaching to the environment, and this becomes irreversible as an attachment when they form bonds via special surface proteins that they have, the adhesins, which are species specific to the matrix. And then they multiply, they are still active, and then gradually they develop even more matrix and they fall into the sessile dormant state, and this is now a mature biofilm. In the dynamic circle of the life of a biofilm, we need to include the dispersal phase, where we have from the periphery of the biofilm dispersing bacteria into neighboring or distant areas. All this process of getting a biofilm and getting it mature is not a long process. It has been reported to be completed within 12 to 18 hours. What it represents, the biofilm and all this creation, is a barrier that makes the life difficult for the host defenses, for the microbial antibiotics to pass through, and also for environmental factors to affect the bacteria. We don't have necessarily antibiotic resistance, but we have tolerance of the specific sessile bacteria under the biofilm, defending themselves to the defenses of our host. And then due to the hyperpopulation and the interspecies interactions, there are also more barriers set within the biofilm that make fighting it quite difficult. And also due to the dispersal, we can have a metastasis of this phenomenon to neighboring or distant areas, and that leads to the chronicity of the infection. To diagnose a biofilm, first of all, we need to suspect it. And we need to be highly suspicious in orthopedics when we have an infection that recurs or is not settling despite the appropriate antibiotics, or if we culture the same, obviously, flora or every time that we go and take samples. And the diagnosis needs samples from the surface of the implant, and then identification of these clusters of cells within their own matrix. The difficulty is which areas now of the implant have the biofilm? Which areas should we culture, especially if we retain, obviously, the implant? And of course, conventional culture techniques are very difficult to identify dormant bacteria, these sessile biofilm-shielded bacteria. If the implant is extracted, we can use, special techniques like getting the implant into a blood culture bottle, or getting mechanical grinding of its surface, sonegation baths, PCRs and DNA sequences, or histopathology tests. All these do make a diagnosis easier, but it's still quite demanding and laborious. Imagine that becomes even more demanding if the implant is retained. Now, to treat it, the biofilm, first of all, we need to understand that when we have an acute infection around an implant and we retain the implant, we should always expect that biofilm will be created. So the shorter time from the infection, obviously diagnosis, to the symptoms, to our first debridement, this needs to be quite thorough, even if we retain the implant, makes sometimes, and most of the times actually, the suppression of infection effective. If not, then we have problems, and of course, local antibiotics and additional strategies as appropriate. When basically the implant is not retained, we remove the implant, we need to make sure that nothing is left behind as far as foreign bodies, dead material, the canal is debrided. I'm sure over the next few hours we're going to discuss further on. And then prevention is usually, the best treatment they take, general measures of preventing site infections, and then more specific measures to prevent the biofilm could be using the alloy we have our implants on, or basically nowadays, not specifically passive characteristics of the surface, but active coatings that can repel or actually fight the bacteria. We need to understand that this effect needs to be exerted immediately on insertion and last for days. To conclude, the biofilm is something that we should be all familiar and suspect in our infections. It makes our diagnosis challenging, the suppression and eradication challenging. It needs prompt surgical intervention to be eradicated and be fought effectively, affecting the antibiotics, and quite commonly the use of advances. Thanks.
Thanks, Nick. Now we'll have Pedro come up. Now we know what we have to worry about on our implants and on our bone and biofilm. And now we'll ask Pedro to give us a talk on how we're actually going to do our debridements.
Thanks, Michael. Hello, all. Okay, so once we diagnose the infection after a fracture fixation, how and when do we have to do the debridement? Okay, remember, this is, I think, a very good statement, that fracture healing can occur completely even when there is an infection of soft tissue and bone. But we need a decreased bacterial activity and a viable vascular environment. So how can we provide this in an infection after fracture fixation? Well, good debridement. We eliminate all dead tissue, and we only leave, if we want to maintain the fixation, the one source of infection, which is the biofilm in the plate or in the nail. So today we are talking about acute. We know from the previous talk that this is not really a real division, but we are talking about infection in the first 2 weeks. In those cases, we have immature biofilm. In most of the cases, we don't have osteomyelitis or osteolysis. Usually it's an aggressive microorganism. And of course, we don't have any callus stability. We only have implant stability. So we need to check about the stability of the implant. We have two broad scenarios, plate infection and nail infection. I will talk mainly about plates, and then Lisa will talk about nails. So when? Well, this is a simple question, but it's not always easy to take the decision because we have to take the patient back to the OR. But the answer is quite simple. It's when any confirmed fracture-related infection. So once you diagnose the infection, you must take the patient to the OR and do a proper debridement. So in these cases, it's quite easy. You see some push drainage through the wound, or you can see the plate. And we know that this is not probably a good fixation. But you need to be proactive, so you don't need to see pus or metal to debride. Don't wait until all the skin is necrotic, because what you will find below is this. So this is a very, very bad case, treated late. So for technique, of course, a traumatic approach, tourniquet, if you want, just you can put it, but not inflate. And always in infection, expansive approach rather than extensile. So you start in the worst part of the wound and you expand your incision as you see the amount of infection. Open the fracture site. There is no superficial infection. Sometimes we are aware of opening the fracture site and thinking they became infected. It's always infected if we have this confirmative criteria. Irrigate with saline and soap. There is no reason to use any other type of devices. And check the stability of the implants. So for the skin, remove all the necrotic skin. And the other soft tissues, you have to remove all the necrotic tissues, especially muscle, but do not strip periosteum and do not remove reactive new bone. Bone, this is probably the worst part. We don't like to remove bone because we know how difficult it is to create. So remove all the denuded cortical fragments and remove the edge until you find bleeding points. Of course, remove implants when you have unstable or inadequate implants. Like this case, this is probably stable, but this is not adequate. And the bride. X-fix, of course, for the nails, we'll have a talk about this, but just remember, remove, ream, irrigate, use a RE or a plastic tube to clean the canal, and only debride the fracture site if you have large cortical fragments or open fractures. And of course, you have to fill the canal with something. Also very important to repeat the debridements. This is like when we treat open fracture, we have to re-debride every 2 days until we have a really clean wound. So in conclusion, be proactive, don't wait. Remove all the cortical denudated fragments. This is sometimes difficult to take that decision, and retain stable implants.
So now we know how to look for biofilms. We've now had a very good, we know how to breed. But if you have been looking in the question and answers, you'll see questions about retaining implants, how to do, what we should do, and about scrubbing. And we'll bring Dave Hahn up from Nottingham to discuss when you make a decision to take the implants out or when you leave them. David? David, hold on.
I have to unmute you.
Yeah, can you hear me now? Aha, got you there, Mike. Welcome, everyone. Hardware retention. We've brushed on it in the previous talks, very good talks, talking about how we bride, how we remove any dead material, but do we leave the metalwork in? And that's the problem. So the first thing to say is that we all get infections. And if you don't get infections, you're not doing enough surgery. And the one thing to do is don't put your head in the sand. You've got to treat these aggressively. It's very easy to diagnose infection in someone else's case. But when it's your own case, you've got to be really honest with yourself. So you do a nice fixation, you've got it all stable, you're very happy with it, and at 10 days, the wound looks like this. What are you going to do? Well, don't send them away and see them in 2 weeks. Be aggressive. Your treatment strategies really are, you are going to do the debridement, as we've heard. We're going to try and retain the implants in this case, or we're going to debride it and we're going to remove the implants and do some temporary fixation or even exchange the fixation. And finally, we may just have to abandon it all, take everything out and come back another day. So how do we make that decision? If you're going to do a debridement and implant retention or a DARE procedure, the key is stability. You have to be honest with yourself that that implant is stable and that construct is stable. Remember, fractures will heal even in the presence of infection, and we've known that from Perrin's work and Castillo's work, but they do need the right environment. So stability of the construct and stability of the implants. And you can assess that by X-ray initially, but also it's at the time of debridement. You've got to tell whether the implant is stable. The X-rays, you're going to look for lucency and lysis, any movement of implants. But it's not only the implants, is the fracture reduction good enough, and is the fracture stable? Remember, it's early infection, so we're not going to see callus at this stage. So in the debridement, as we've heard from Pedro, it's quite aggressive. You take everything out that's loose or necrotic, all the foreign bodies, including those deep sutures you put in or suture anchors, because they're a nidus to hold that infection. And Nick has told us a lot about biofilm. It will be there, it will be early, hopefully, if you've got an early infection. So it may be reversible. But the biofilm is likely to be at the bone implant interface. And so you've got to debride deep down onto the bone and the implant and remove any of that slime and that material that we often see. To be able to do that, you've got to have adequate visualization. There's no point in just partially opening it. You've got to see that whole plate because we don't know where that biofilm is forming. But remember, once you've done all that, you've got to identify the specimen, the organism. And that means deep and multiple specimens. And we have a special pack of 6 sets of scalpels, forceps, all individually packed, and each one is for one specimen. And it's a tissue specimen, not a swab. So a deep tissue specimens, we use 6, 5, at least 5, but we use 6. And they've got to be from various places, and document where you've taken them from. If you're going to retain that implant, then you're going to be looking at trying to prolonged suppression of the infection, or if it's a sensitive organism, you may be able to treat it and eradicate it, but very often we're just trying to suppress it and allow fracture healing to continue. But if you're going to do this, you've got to have a high index of suspicion, and any change in the wound, once you've done your first retention, you've got to be prepared to go back in again and reassess whether the stability is still happening. Now, as we've alluded to, nails are a bit difficult. So with the plate, it's easy. You're going to be able to see it from the previous surgical incision. With a nail, it's very difficult to get deep specimens if you're just doing an open debridement of the wounds. Remember, you're probably not even going to get to the fracture site. If the infection appears to be at the insertion site, then how do we know whether the infection is down at the nail and the fracture site? So although we can suppress and retain, we've got to have a very high suspicion that there may be infection down the canal. In that case, as we'll learn later on this morning, we may consider doing an acute exchange, or even pulling the rod out completely and reinserting something else. And we may need better imaging, including CT scans. So we have a nice fixation. We're all very happy, and the wound looks like that at 10 days. It is leaking. We're suggestive of infection, but we have no implant. But then just before we take them to the OR, we get another X-ray, and now we see that screw is loose. Now, if that screw is backing out on its own, we've got to suspect that there is a deep infection involving even the bone. So when we come to debride it, it looks stable on the first x-ray, but on the second x-ray, we're beginning to wonder. And actually, when we get in there, we find that all 3 screws are loose in the bottom end, and the bone is necrotic. And in that situation, the debridement is much more extensive, taking out the plate, the bone, and all necrotic tissue, and we're going to temporary provisional stability with an external fixator, and then we've got a plan going further down the line and reconstructing. With the rods, as I explained, debridement may include remove the nail, reaming the canal, and we'll hear a lot about that later on. So in summary, if you're going to retain the hardware, it is possible if, after debridement, the implants and the construct are stable. You must do everything you can to identify that organism and start appropriate antibiotics, and you will have to do very careful surveillance if you are going to retain implants. Debridement may involve exchange of hardware, especially the IM rods, and all loose and unstable fixations should be removed at your initial debridement, and you switch to an alternative stability, usually with external fixation or antibiotic nails. And once again, identification of the organism and appropriate antibiotic regime is essential. Thank you, Mike.
Thank you, Dave. So we're back to our case. So what are we going to do now? And I'll ask faculty that want to say something to come on. I think we have a couple different options here. We've heard about making the diagnosis. I think it's clear here. We have a draining wound that was previously dry. We have an effusion. We have air. And then we heard about biofilm retaining our implants and how to debride. And so we have a couple different surgical options here. We could just try to aspirate and put them on antibiotics, debridement and revising the fixation, or debridement, removal of the hardware, and external fixation. So David, how would you go ahead and attack this?
So looking at the x-rays that we've got there, it's pretty stable construct. The reduction is not perfect, but yeah, I would accept it if all screws were stable. And I think you obviously got to go an acute debridement of the wound, have a look inside, expose the plate fully, take some biopsies, and if with use of x-ray in the operating room, I felt the construct was stable, I would probably try to retain this rather than take it all out. But it would depend on what it looks like at the debridement.
Okay. And David, you talked about retaining hardware and it has to be stable. How do you determine that?
Okay, so first you look at the x-rays and then, as I said, the stability, you can't just go on x-rays. They all look great because if it's your own case, you're pretty sure you did a good job. But they can loosen, and you can screen it in the operating theatre just to check that there is no movement of the fracture or the implants. And then when you actually get in there, you look at the screws, even turn them, just check they're tight, and make sure there's no instability that you're being fooled to think it's okay. So it's really an assessment at the time of debridement.
Yeah, that was where I was going, is I always have a screwdriver available to test my screws and make sure that they're functioning. If they're not functioning, I take them out because they're just more foreign body, and maybe add a different screw. Nick, did you have something to add?
Yeah, I want to add that this X-ray makes me even more uncomfortable. The stability is exactly as Dave described. It looks, stable, but it is an interarticular fracture. So the joint here is an additional concern. So that makes, inclusion of the wash out of the joint or sampling the joint as well a parameter, and makes this first debridement even more urgent than just observing the CRP climbing.
Right. Pedro?
I think there are two questions in the question and answer chat, maybe for Nick or for Wilhelm, about the biofilm. So what's the role of the surface in the adhesion of bacteria. I think you already answered this, but maybe you can talk a little bit more.
This is an evolving understanding in regards to, active or passive factors of the surface of an implant, if that affects the adhesion. But I think, in my understanding, what we've realized that the bacteria do not adhere to necessarily the implant surface, but to this conditioning film, which is byproducts of blood, and fibrin and other proteins of the host. So the surface characteristics play less of a difference, except if they are active coatings or active, surface characteristics that they repel or they, obviously kill the bacteria. So the surface characteristics are the least important into this adherence, initial adherence in the creation of the biofilm.
Okay.
Answers, yeah.
I have one other question for the faculty, whoever would like to take it, and that is, so in this case, if we remember back to the CAT scans, not only do we have wound drainage and infection next to the plate, we also have an effusion. Do you debride that differently? Is it all done through one incision? Is it done through a second incision? How do you like to best attack that, Dave?
If there's an effusion in the knee, initially I'll just aspirate it. And I don't want to open up into the joint because that immediately communicates everything. I mean, you could argue it's communicating anyway, but I'd like to keep that capsule closed and I would aspirate the joint. If I get pus out of the joint, then it's way up the knee as well. But if it's just clear fluid, then I'll send that off as part of specimens.
Yeah, I wish I have come under that and have had clear fluid. But typically my experience, especially with tibial plateaus, is that if there's pus coming from around the plate, it's pretty likely that there's pus in the knee as well. And I think that needs to be debrided. And I was just curious about how you would do that. Wilhelm, I see you came on. Would you like to make a comment about that?
Yeah, 2 points. Indeed, I agree with you, Michael. So in this case, if you open up, you enter the knee, this will be full of pus. So you need to really clean it and use a lot of fluid to clean the knee. I think that's crucial here. And maybe come back to the biofilm. We had some questions on the surface of the biofilm itself, and if it's positively or negatively charged. So we know it's often negatively charged, and therefore some companies and research groups, they develop positively charged implants because it could have antimicrobial efficacy actually. So just to answer on the questions that popped up in the chat room.
Thanks, Wilhelm. So let's move on. In this case, patient was taken to the OR. The plate was visualized. The screws were tracked. There was a question about whether you unlock the screws and check them to see if they have purchase. I don't, because you're never going to know if they have end purchase. So if they're locked, they're fine. They are providing some stability. The patient does have septic arthritis. I have a bias. I don't know, and if anyone wants to comment, they can. I do not like to go back through my submeniscal arthrotomy because I'm afraid that if I go back through the submeniscal arthrotomy, I'll never be able to repair that. And I do a separate small medial incision, medial parapatellar, to wash to inadequately debride the knee joint. So I do 2 incisions, one for the plate and the infection there, and one for the arthrotomy, and an arthrotomy through a medial incision to wash out the knee joint, because I think it's critical to do that, and then do some cultures and local wound management. Dave first, and then Nick.
Yeah, I agree with that. If so, this guy's got septic arthritis, so I'm going to do a proper formal arthrotomy away from the wound, and so I can get a much better debridement of the wound rather than trying to lift up that meniscus again. I mean, that will be part of the debridement of the superficial, but I won't re-enter the joint through that wound. I'll make a separate incision. and debride. And I'll often use an arthroscopic shaver to get rid of the synovium, because if you're going to do it, you need to debride the joint properly, not just keep washing it out. Synovium holds that bacteria in.
Yep, I do that through. I just do it open. Nick, did you have a comment?
Same story. I mean, usually I do first the wound wash out for the plate, and then as an end stage, via the arthroscope, sampling of tissue from the, the capsule aspiration. If it's gross pus, obviously full wash out. If not, it may be a second wash out, arthroscopic or open, pending the results of the cultures from the, first arthroscope. But via a scope, I think you can do that first stage.
So you could do a scope first, debridement, and then do your washout of your implant. I think that's acceptable as well. I think the key here is that you have to not forget about the knee joint if you have a tibial plateau, because I think by definition, if you have an tibial plateau infection, and especially in the earlier stage, there's absolutely communication through the fracture site. The other thing here is the decision was made to not revise the joint. It's not perfect. The gentleman is a little older. It's probably a little worse than not perfect. But at the same time, trying to fix this, an infected bone, to get stable fixation when you already have an infection may not be the best idea. If the patient was 20, you may consider it, but in an elderly patient who's retired, who wants to just get back to refereeing, I decided, this is my case, I decided not to do it. So unless there's anything else, I'll move on. I think Willem was on, but then I think he was just, somebody said what he wanted to, so we'll make that assumption. If he comes back on, we'll discuss more. So cultured MRSA, stability, placed on IV vancomycin. Here he is at 8 weeks. I don't know how the reduction appears better. I'm sure it's just projectional. And here he is at 1 year, refereeing football again, and very happy. And so the take-home message here is to, again, as David said, do not, don't stick your head in the sand. Somebody has effusion and has drainage from a previously dry wound, take them to the OR. You can get the fracture to heal. And if we have to take the implants out, we can always do that later. I'm now gonna, hopefully this will work. Okay, so we're gonna move on to case number 2. And here we have a 29-year-old with a tibial plateau fracture. You can see here some intraoperative films and a reduction. So probably a little bit better reduction in this case. And here we see some follow-up. 3-week post-op visit. He comes in with increased knee swelling over 3 days. He had a large effusion of 140 cc's with 120,000 white cells. This was a patient who was actually cultured in the office in the clinic because he just presented with effusion and not drainage. So there's several reasons, but clearly here with a white cell count and an elevated C-reactive protein, he actually cultured out very quickly pan-sensitive staph. So we can talk about this again if anyone has anything more or different to add. It's pretty much the same presentation in a younger patient with an adequate reduction. And so we could talk about the same things, whether we want to do the same aspiration, antibiotics, surgical debridement only, debridement and revision fixation, or debridement and removal of hardware with external fixation. But I think given the same circumstances in a 29-year-old with what appears to be stable fixation going in, again, we'll test it. It's the same treatment algorithm that we had before. And the patient was taken to the operating room, had an arthrotomy and a lateral approach. Here he is now at 4 weeks. He came in at 3, here he is at 4. And we see a washout with some local antibiotic beads. So at this point, let's talk a little bit about local antibiotic beads and what they can do for us for local antibiotic delivery. And we'll bring Mohammed Wajid up to give us a talk on that.
Okay, thank you very much, Michael and Pedro, for the kind invitation. It's an honor. And my remit is just to go through the resorbable antibiotic delivery mechanism. Once we have debrided the wound and decided whether the implant is going to stay in or out, local antibiotics are a very useful adjunct for the control of infection, because that's where the problem is, and we want to have maximum antibiotic in the area. So in next 5 to 6 minutes, I will go through the role and effect of local antibiotics, what delivery mechanisms for local antibiotics we have, and the main focus in this talk is absorbable carriers for antibiotic delivery. It's a well-known fact that administration of local antimicrobials in addition to systemic therapy may be beneficial because that's where the problem is, and we want to have a maximum concentration of antimicrobials where the focus of infection is. How we can deliver that? With local delivery, that it may reduce the total drug amount which has to be delivered through the system, and it leads to increase local concentration up to 1,000 times the minimal inhibitory concentration of antibiotic required for the stoppage of the growth of microorganisms. However, there is another side to it, because there is a concern that high local concentration may produce cell toxicity, leading to attenuated healing, because at the same time there will be new cells proliferating, which we want for the fracture healing, but a very high level of antibiotic may lead to cell toxicity. So intuitively, why not we just sprinkle some antibiotic where we have already debrided the wound? But we see that there is only one randomized controlled trial which found no difference in infection rate when vancomycin powder was used in addition to systemic prophylaxis. And normally it is not a common practice that we put intra-wound antibiotic powder. And it has not been studied extensively in our literature. And to date, antibiotics without a carrier has not been documented in human trials for fracture-related infections. So how we deliver then the antibiotic locally? There are various mechanisms. It can be in addition, along with the autograft or allograft. We all know bone cement, ceramics, biodegradable and bioactive glass, poly-DLL lactide, collagen sponges, hydrogels, and then there are non-antibiotic antimicrobial strategies. So my remit is basically for the resorbable ones. So can we mix the antibiotic with an autograft? Because once we are putting an autograft, is it possible? Routine mixing of local antimicrobials with autogenic cancellous bone graft is not recommended as standard of care. So if we are using just the bone graft, it is not a common practice to mix it with antibiotics. What about allograft as an antibiotic carrier? Allograft may be modified by porphyrin adsorption, antibiotic impregnation, antibiotic tethering, and chitosan heparin coating. This increases the storage capacity and release profile more than the PMMA, if we can do that. This is the main topic, main focus of this talk is the biodegradable ceramics. So how we can deliver antibiotic and the carrier will be dissolved and we don't have to take it out. And there are two options. We have calcium sulfate and calcium phosphate. And antibiotic elution is above the minimal inhibitory concentration for between 3 to 4 weeks. So if we mix antibiotic with calcium sulfate or calcium phosphate, the elution happens between up to 3 to 4 weeks. And it is superior to PMMA. And there's a randomized control trial of osteoset T versus antibiotic-loaded PMMA. There is no difference in infection eradication or union amongst the two groups. However, more surgical procedures naturally are required if we put a bone cement in. Biodegradable ceramics. Ceramide is another one, which is a flowable, cold curing composite of 60% calcium sulfate and 40% hydroxyapatite. In a comparative study of osteoset T versus ceramide G for antimycin groups, the refracture and infection reoccurrence was 2 times less compared to with those in osteoset T group. So in ceramide G group, the incidence of refracture and recurrence of infection was 2 times lower than osteoset T. Biodegradable poly-DL-lactide, we can coat an implant with that. It's a new development, and the only one which is marketed nowadays or is available now is ProTech tibial nail, which is the only commercial available implant for this purpose. It is coated with a layer of PD-LLA impregnated with gentamicin. There are 2 studies that evaluated the device in acute complex fracture and revision cases. And the outcome was there is no post-op infectious complications. So delivery with other absorbable carriers, collagen sponges, hydrogels, clinical studies focusing especially on fracture-related infection are limited for these 2 absorbable carriers. The take-home message is the local delivery of antibiotics significantly increases availability of the antibiotic. Ceramide G and osteoset T show promising results. Only available implant, which is the tibial nail, which is antibiotic-coated commercially available implant, is this one, which can be used to increase the antibiotic delivery in high-risk cases. Thank you very much. Over to Michael.
So there is thank you, Mohammed. I just want to point out that this is a case of mine that has some calcium sulfate beads. You can see a string of beads right here. Let me show you. You can see a string of beads right here. And this does create sterile fluid. In Mike McKee's paper, some of these patients had drainage, and it was sterile. And be careful, I was called about this patient who was asymptomatic but had an abscess supposedly. But this is just the normal fluid that was appearing around his beads. He had no pain, he had no elevated markers, his white count was normal, everything was fine, and it was just a routine CT scan that was occurred. So let's move on to our case. So here he is at 6 weeks post irrigation debridement, and his beads have absorbed, as you can see here, over the 6-week course. 6 months later, he comes back. He has a large effusion. His white cell count is 91,000. He has an elevated markers of C-reactive protein and his white cell count. Here's his videos of his infection, and you can see that there's a large hole in his metaphyseal area right where there was that suture anchor. I think in retrospect, maybe we could have done something a little bit more with that. It's not quite playing. And here's the axials. And we can see here, you can see a large effusion again, and then some debris, and then some bony holes as well, right there. So back to our slides. So now we have a reinfection. He's taken back to the operating room at this point, but his fracture is healed at this point. And because we have pus, we did a washout again, medial arthrotomy, and a lateral incision for his plate, took his plate out. We placed local antibiotic beads, once again, calcium sulfate. We removed the area and debrided thoroughly the area of bone and placed the beads deep into his bone. 5 months after his second washout. His joint doesn't look good, but his range of motion is 0 to 140. He has minimal pain. He's exercising in the gym, and the only thing he hasn't gotten back to is running. So the thought process here is able to get the fracture to heal. The infection reoccurred, and then we removed the hardware and used local antibiotics. So again, same treatment algorithm as in the first case, but in this case, our infection reoccurred, mandating that we had to take out his hardware. But it was much easier to deal with the infection the second time than if we had taken out all the hardware with an adequate reduction the first time. So let's move on to the next case. We now have a 46-year-old man with a left open tibia, grade 3B. He also had a right open tibia, a left acetabulum, and a left femur. So we have a polytraumatized patient. On night one, this side of the tibia was a little, had a lot of necrotic tissue, and he had, and it was clear that bone had to come out. It was also clear that he was going to need a free flap because of the large wound issue. So this temporizing plate just to work as an internal X-fix, no more stripping was done. We nailed the fibula to get some stability of the overall limb, and he had some antibiotic beads placed in as well. On day 2, he had his repair of some of his other injuries, and he was taken to the operating room at this point for his tibial nail. And the plan was to take it, to do a tibial nail, remove the plate, and what we found was gross purulence all over the place. So I'd like to ask the faculty at this point what they would do when they come back in to plan on their definitive treatment, but they have to maybe change their plan. So I see George coming on. George, what do you think?
I think at this point, a good idea would be to use an external fixator to plan on a 2-stage revision. It will buy you time when you get the chance to control the infection.
Okay. I think that's a reasonable, Wilhelm?
That's a good option. You could even suggest, in my opinion, to go for definitive ring fix if it's really unstable, not clean, and you don't want to have any implants in place at that time.
Okay. Jean-Claude?
I would agree. I have a bias towards ring external fixation, particularly with infections. At a minimum, you're going to have to do something else for at least temporary stability. So your internal fixator is now bathed in pus, and so I think moving your metal out of the wound bed to a monolateral frame if you're still committed to nailing this. But for me, this patient's already bought ring fixation.
Okay. So what was done here, so we still went ahead and, he was debris, so he was taken to the OR. We had gross purulence. We debrided him 3 times, and it was a very early infection. It's rare for me to even see an infection at a second washout, but that's why we do second washouts. So at this point, his wounds were clean and ready for a flap. And so the thought process is now his wound is acutely clean, and we went ahead and put a nail in, but he also had a spacer placed to cover the nail and protect it from the outside world, but the nail was placed at the same time as his flap was placed. I just want to show everyone now how some tricks and tips for making our antibiotic spacers. You should really want to incorporate it into your into your bone defect management, and it should be part of your montage and your construct. So here we can see on the left-hand side, we see the nail and the plate in place. The wound is relatively clean. All the necrotic bone and soft tissue have been debrided multiple times to get a clean bed. but we don't want to just go ahead and leave this nail exposed. I think that's not a great idea because there can be infection that goes up and down the canal. I have these metal retractors. Again, no soft tissue stripping because it's all gone already, protecting the undersurface and the posterior compartment and the artery and nerves around in the area. And I put my cement in that's when it's warm still, or when it's still liquid, not liquid, but starting to firm up. And I put it in and it becomes part of the montage and it becomes part of your construct for stability and covers your nail. Now, the key here is to not let the cement get hard. And what you can do with this is continuously irrigate as you're doing, as you can see here that the cement is firming up, and I'm continuously irrigating this to keep the cement from getting hard. And when you do that, from getting hot and not cooking the tissue around it, you don't want to burn any more bone. And if you continually irrigate it while you go ahead and do your, while it's